The medications we take daily can harbor unexpected risks to our health. This review will cover 6 common medications that may be subtly increasing the likelihood of a heart attack. Understanding these hidden threats is critical for anyone looking to make informed decisions about their well-being. Hormonal contraceptives play a key role in family planning and women's reproductive freedom, but their use is associated with certain cardiovascular risks. It is important to understand these risks in order to make informed choices about contraception. Combined hormonal contraceptives, CHCs, which contain both estrogen and progestin, come in various forms such as pills, patches, and vaginal rings. Studies show that CHCs can increase the risk of arterial thrombotic events, including myocardial infarction, heart attack, and ischemic stroke. A large Danish study of over 2 million women aged 15 to 49 found that women taking pills containing a combination of estrogen and progestin had twice the risk of such events. In absolute terms, this means 1 additional stroke per 4,760 women, and 1 additional heart attack per 10,000 women per year. Notably, non-oral CHCs show even higher risks. For example, vaginal rings are associated with a 3.8-fold increased risk of heart attack. The main mechanism is thought to be related to the effect of estrogen on the blood clotting system, leading to a prothrombotic state. Estrogen can enhance the synthesis of clotting factors, increasing the likelihood of blood clot formation. This effect is especially important for women with additional risk factors such as smoking, hypertension, or hyperlipidemia. Progestin-only contraceptives, available as pills, injections, implants, or intrauterine devices, IUDs, generally have a lower cardiovascular risk profile compared to CHCs. The same Danish study showed that progestin-only methods were associated with a slight increased risk, but significantly less than their estrogen-containing counterparts. It is important to note that progestin-only IUDs did not show an increased risk of heart attack or stroke, making them a safer option for women concerned about cardiovascular complications. But these are not all the drugs that can negatively affect the heart. What other medications can be dangerous? Watch to the end to learn more and protect your health. Nonsteroidal anti-inflammatory drugs, known as NSAIDs, have become widely used as pain relievers, inflammation reducers, and fever reducers. Common over-the-counter drugs such as ibuprofen and naproxen can be found in stores everywhere. Despite their proven effectiveness, it should be considered that the use of these medications is associated with an increased likelihood of developing cardiovascular complications such as myocardial infarction and stroke. The mechanism of action of NSAIDs is based on the inhibition of cyclooxygenase, COX, enzymes, in particular COX-1 and COX-2. These enzymes play a key role in the synthesis of prostaglandins, lipid compounds that mediate inflammation and support various physiological functions of the body. Suppressing the activity of these enzymes can disrupt the delicate balance between vasoconstriction and vasodilation, as well as platelet aggregation, which in turn increases the risk of thrombotic events. This imbalance is especially dangerous for people with a history of cardiovascular disease. Numerous scientific studies confirm the association between NSAID use and an increased risk of developing cardiovascular disease. The U.S. Food and Drug Administration, FDA, specifically notes that the likelihood of a heart attack or stroke may increase in the first few weeks of NSAID use, and this risk tends to increase with longer use and higher doses. It is important to emphasize that this warning applies to both over-the-counter and prescription NSAIDs. A large review published in the European Cardiology Review carefully analyzed the cardiovascular consequences of using both traditional NSAIDs and selective COX-2 inhibitors, COXIBs. The authors of the review emphasized that the cardiovascular side effects caused by NSAIDs have long been underestimated, which has led to increased awareness of the potential risks associated with their use. It is worth noting that not all NSAIDs have the same level of cardiovascular risk. For example, diclofenac has been associated with a higher likelihood of serious vascular events, including myocardial infarction, compared to other drugs in its class. At the same time, naproxen appears to have a more favorable cardiovascular risk profile among NSAIDs. Given the potential cardiovascular risks, extreme caution should be exercised when using NSAIDs. Before starting NSAID therapy, the patient's cardiovascular history and risk factors should be carefully evaluated. The minimum effective dose should be prescribed for the shortest duration necessary to relieve symptoms. Blood pressure should be monitored regularly, and signs of heart-related side effects should be closely monitored, especially in patients taking NSAIDs for a long time. For patients with high cardiovascular risk, alternative pain management strategies that carry less health risk should be considered. Thiazolidinediones, a prominent example of which is rosiglitazone, were originally developed to improve blood glucose control in patients with type 2 diabetes. Their action is based on increasing the body's sensitivity to insulin. However, concerns regarding the cardiovascular safety of this drug have significantly impacted its use in clinical practice and its regulatory status. Rosiglitazone acts as an agonist of the peroxisome proliferator activated receptor gamma, PAR. Activation of PAR affects the transcription of genes involved in glucose and lipid metabolism. This leads to increased sensitivity of peripheral tissues to insulin. Although this mechanism effectively lowers blood glucose levels, it also affects fluid balance and lipid profiles, which can have negative consequences for cardiovascular health. The issue of rosiglitazone's cardiovascular safety has been the subject of numerous studies and lively discussions. A meta-analysis published in the prestigious New England Journal of Medicine in 2007 revealed a 43% increased risk of myocardial infarction among patients taking rosiglitazone. Numerous studies confirm that rosiglitazone is associated with an increased risk of developing heart failure. A comprehensive meta-analysis concluded that, although there was no significant increase in the risk of myocardial infarction or cardiovascular mortality, the risk of heart failure was significantly higher. The results of observational studies regarding the association between rosiglitazone and stroke or all-cause mortality have been mixed. Some analyses indicate an increased risk, while others do not find a statistically significant increase. The controversy surrounding rosiglitazone highlights the importance of careful post-marketing surveillance and comprehensive assessment of drug safety profiles. Clinicians should carefully weigh the benefits of glycemic control against the potential cardiovascular risks before recommending thiazolidinediones for the treatment of diabetes. In most cases, alternative medications with more favorable safety profiles are preferred, especially in patients already suffering from cardiovascular disease or with risk factors. In modern medical practice, antidepressants, in particular tricyclic antidepressants, TCAs, and selective serotonin reuptake inhibitors, SSRIs, are widely used to combat depressive conditions. Despite the proven effectiveness of both classes of drugs, their potential impact on the cardiovascular system must be considered. Tricyclic antidepressants, such as amitriptyline and nortriptyline, work by blocking the reuptake of neurotransmitters, such as norepinephrine and serotonin, which helps to improve mood. However, their pharmacological properties can have a negative impact on heart function. TCAs can cause a sharp drop in blood pressure when transitioning to a vertical position, leading to dizziness and an increased risk of falls. This effect is due to their antagonistic effect on alpha-adrenergic receptors. In addition, these drugs can slow down cardiac conduction, which is reflected in the prolongation of the PR, QRS, and QT intervals on an electrocardiogram, ECG. Such changes can provoke the development of arrhythmias, including ventricular tachycardia and fibrillation. Often, TCAs cause an increase in heart rate due to their anticholinergic effects, which can be especially dangerous for patients with pre-existing heart disease. In this regard, the appointment of TCAs to people with cardiovascular pathologies requires special caution, and in some cases it is preferable to consider alternative treatments. Selective serotonin reuptake inhibitors, SSRIs, such as fluoxetine and citalopram, selectively block the reuptake of serotonin, which helps to improve mood. They generally have a more favorable cardiovascular safety profile compared to tricyclic antidepressants, TCAs. However, some SSRIs, particularly citalopram and escitalopram, can cause dose-dependent QT interval prolongation, increasing the risk of a rare but dangerous arrhythmia known as torsades de pointes. Because of this risk, the FDA recommends limiting the maximum daily dose of citalopram. Although less common than with TCAs, SSRIs can sometimes cause orthostatic hypotension and slow heart rate. These effects are usually mild but require monitoring, especially in patients with pre-existing cardiovascular issues. Overall, SSRIs are often the preferred choice for patients with depression and coexisting cardiovascular disease due to their safer side effect profile. However, individual risk factors and potential drug interactions should always be considered when choosing a treatment method. Pseudoephedrine, widely used as a decongestant in many over-the-counter cold and allergy medications, is effective in relieving nasal congestion but carries potential cardiovascular effects, especially in individuals with heart conditions. Pseudoephedrine works by stimulating alpha-adrenergic receptors, leading to vasoconstriction in the nasal passages. This constriction reduces swelling and facilitates easier breathing. However, this effect is not limited to the nasal tissues. Pseudoephedrine can cause vasoconstriction throughout the body, which can affect cardiovascular function. Specifically, pseudoephedrine can cause elevated blood pressure and increased heart rate due to its systemic vasoconstrictive properties. Studies show that in patients with controlled hypertension, pseudoephedrine use can cause a moderate increase in systolic blood pressure. Medical literature reports link pseudoephedrine use to acute coronary syndromes, such as myocardial infarction. The drug's sympathomimetic action can increase myocardial oxygen demand, potentially triggering heart attacks, especially in predisposed individuals. Pseudoephedrine can also cause arrhythmias, including tachycardia, rapid heartbeat. These effects are particularly significant for people with existing heart conditions or those taking other medications that affect heart rhythm. Individuals with cardiovascular conditions, such as hypertension or arrhythmia, should consult a healthcare professional before using medications containing pseudoephedrine. Alternative treatments with a more favorable cardiovascular profile may be suggested. Even healthy individuals are advised to monitor blood pressure and heart rate when taking pseudoephedrine, especially when using high doses or during prolonged use. Pseudoephedrine can interact with other medications, such as monoamine oxidase inhibitors, MAOIs, and beta blockers, which can exacerbate cardiovascular effects. Informing healthcare providers about all medications being taken is essential to prevent potential adverse interactions.